Right, good afternoon, everybody, and welcome to this week's deep dive session, which has a slightly different flavor from the norm in that we are going to look at a common topic, but more specific to, or let's say more broadly, to our sub-Saharan Africa context, and that is multiple myeloma. And for that, we're very fortunate to have two great people with us in the room. Dr. Moses Chatambutsa and Dr. Judith Mangwayana. And Moses will be co-chairing this session with me. And I think we're going to get straight into it, but just a few housekeeping points before we get started. Around the top of the hour, we will have a link in the chat box through which you can register your attendance. So there will be a link to click on, which will take you to a RedCap page, and you can basically do everything within 30 seconds and also ensure that your email address is captured for future reference and invitations. And secondly, please feel free to put your questions in the chat box. There will be an opportunity a bit later to also ask questions, but if you don't want to speak up in person, please add any comments or thoughts or personal experiences in there. So I'd like to start by welcoming my co-chair for this afternoon, Dr. Moses Chatambutsa. Now, Moses is well known to many of us. He obtained his BSc honors in human physiology as well as an MBCHB from the University of Zimbabwe. He then went on to complete his internship at Parianyatwa group of hospitals in Harare, and I'm sure Moses is going to help me get that corrected. Is it Parianyatwa, Moses? It's a very difficult name.
That's correct, Prof.
That's
correct.
Thank you. He subsequently joined the Department of Molecular Medicine and Hematology at WITS, where he completed his MEd in hematology first, as well as his FC Path in 2019, and then subspecialized in clinical hematology also at WITS, and passed his exam in June last year. And I can testify, having been an examiner of Moses, that he's a brilliant clinical hematologist. He's got specific research interests in multiple myeloma, bleeding disorders, and myeloproliferative neoplasms. And Moses has returned to Zimbabwe, and he is currently working at Parianyatwa Hospital and the University of Zimbabwe. Now, I'm going to hand over to Moses, who is not only my co-chair, but will also be talking this afternoon on the diagnosis and management of multiple myeloma in sub-Saharan Africa. And Moses, if you would also be so kind, when the moment comes, to introduce your colleague and co-presenter this afternoon. Thank you. Over to you, Moses.
Good afternoon, everyone. Good afternoon, Prof. And thank you, everyone, for joining us this afternoon. And thank you to UCT team and the deep dive organizers for inviting us to present something from Zimbabwe. It's a great opportunity that we gladly took. Thank you to Estelle as well. Today we are going to talk about multiple myeloma in sub-Saharan Africa, which is essentially the region, about 46 countries in Africa, excluding the 7 countries in the Northern Africa. And as you are going to see as we present, there's quite a lot of variability of the way this disease is diagnosed and managed in sub-Saharan Africa. And to start this session, we thought we're going to present Dr. Judith Mangwayana, who is joining me, is going to present initially a case study, essentially a case of multiple myeloma, and she'll present another one during my presentation. So I'll just introduce Dr. Judith Mangwayana. She's one of our registrars here at in hematology unit at University of Zimbabwe. She's in her second year. she's quite passionate about myeloma, I think for personal and family reasons, but also she's going to start her MED also, I think, in multiple myeloma. So Judith is going to present one of the patients that we managed here in Harare in multiple myeloma. Judith, can you hear me? You can start sharing your screen. Judith, can you hear me? Yes. Yes, we can see your screen. You can unmute and start the presentation.
Good afternoon. Can you hear me now?
Yes, we can. Thank you.
All right. So I'll start my presentation. Good afternoon to you all. I'm going to present a patient that we saw here in Harare. Our patient was missed RM. He's 45 years old. He's a boiler maker and works in one of the mines in Zimbabwe. He came in as a referral from the neurosurgeons in April of this year, and he came in with a spinal cord compression. The neurosurgeons had done a CT-guided biopsy on him, which showed that he had a plasmacytoma. So when the patient came to us, he was complaining of a backache and he had reduced mobility in his lower limbs. Initially, this patient, a year prior to this presentation, he has had presented to his GP with backache, and he was treated with analgesia on and off for that in that last year. So when he presented to his GP, he was mainly complaining of this backache, and he thought that it would be noble to give him analgesia. And then when he subsequently again presented to the same GP with backache, the GP then decided that he should have x-rays. And x-rays of the spine were done, which were essentially normal. And then 4 months prior to his presentation, the backache got worse and he reduced his mobility. That's when the GP decided to send this patient to Parenyatwa. And when the patient got to Parenyatwa, because he had a back problem and he had reduced mobility, you ended up in the neurosurgical ward. The neurosurgeons did an MRI on him and saw that he had a compression around T1 to T4. That's when they decided that they should do a CT-guided biopsy. We then showed that the patient had a plasmacytoma, and subsequently the patient came to us as hematologists. So when we saw the patient in April of 2021, the patient had an ECOG score of 4. He was bedridden, and his power in his lower limbs was reduced. He had a power of at least 2/5. His sensation was intact. His bladder control and bowel control were normal. So when we saw the patient, we ran a series of tests. Initially, we did his FBC, and he had an anemia of 10.2. His platelet count was normal. His neutrophil count was normal. He also had urea and electrolytes done, and his kidneys seemed to be working well. His sodium was 139. The potassium was 4.1. The urea and the creatinine were normal, with a urea of 3.6 and a creatinine of 56. Subsequently, also did a calcium level, which was normal, it was 2.32. But of note was that his total protein was high, which was 99, and he also had a hypoalbuminemia of 27. At the same time, we did serum protein electrophoresis, and his M component was 49. His lambda to kappa ratio was 1:1. At the same time, he also did a bone marrow aspirate, and we noted that he had eccentric cells, mainly plasma cells, which were more than 70% on bone marrow aspirate. We also wanted to do his LDH and serum beta-2 microglobin, but these were not done due to resource constraints. At the same time, we also staged our patient, and we saw that on the Jury Salmon staging, it was at least stage 3, as the patient had a lot of lytic bone lesions by the time we saw him. We then decided to go on to plan his treatment. So this was a joint treatment. It was the radiotherapist and the hematologist. So we sent him to the radiotherapy station at Perenatwa, where they gave him 1.5 grays of radiation each day, and he had 15 sessions. At the same time, on our side is a hematologist. We put him on bortezomib 2 milligrams subcutaneously once weekly. We also gave him dexamethasone 40 milligrams IV once weekly. He was also on thalidomide 200 milligrams once a day for 21 days in each of his cycles. The patient also subsequently received zoledronic acid, which was 4 milligrams once every 6 weeks, given in 200 mils of normal saline. At the same time, with the multidisciplinary approach, when the patient came in, he was almost bedridden. After he received a few sessions of radiotherapy, about 4 of them, he was now getting a little bit better, and also he was no longer demanding as much analgesia as we're giving him at the beginning of the sessions. So we then decided to have a joint management of him with the physiotherapist, and he started receiving physiotherapy regularly. And initially he was coming into the clinic on a Zimmer frame, and up to now, when he's on his 11th cycle, he's now walking on his own without using a Zimmer frame. So if we look at his results as he was on the treatment that I outlined above, his white cell count remained within the normal limits from the beginning of the treatment up to now. He had initially started with an anemia of 10.1, but he has since recovered from the anemia. As of June 2022, his HP was 15.9. His platelet count is slightly increased. It was normal, but it has been increasing now. We've got a platelet count of 337, which is still within normal limits. Our patient, fortunately, didn't have much problems in terms of the renal function. His renal function remained within normal limits from the beginning of the treatment. At the same time, we also did we also did his total protein. When we started treatment, our patient had a total protein of 99, which was very high. But now, as he has been on treatment, his total protein is now 76. His albumin initially was very low at 27, but now with his treatment, his albumin level has actually risen up to 44. And so this is the progress of our patient from the time we began up to now. We have also seen that our patient had an echo score of 4 at the beginning, but at the present moment, to this date, he's now on his 12th cycle of BTD. And the patient also awaits a possible bone marrow transplant. Thank you.
Thank you, Judith. That's our first case presentation. I don't know if there are any questions, or maybe we have questions after I've presented. You can unshare your screen, Judy, so that I can share mine.
All right.
Maybe one or two quick questions, Judith. Thank you for a great presentation. So I just wanted to hear the reason why you gave more than 6 cycles of VTD. Was that because consolidation with transplant was not an option?
We gave him that because when we were, if I go back to my screen, if you look at the results, the time when he was around the 6th cycle, he just had a slight increase of the M protein. It was 15. And that's when I consulted my seniors and we thought that we should continue with the treatment. And then that's when it came to a level of 10. At the present moment, we are still at 10.
Can you quickly show us that spreadsheet again, just for interest's sake?
Let me bring it back.
So while Judith is doing that, just for our junior colleagues, so as we always say, the deep dive on a Monday is the primary audience is our trainees. And even though we use the revised international staging system, when you are limited in resources, as Judith mentioned here, they can't do. I think I was just disconnected for a moment. Could you hear what I was saying?
Yes, Prof, I could hear you.
Okay, right. So just to, as a reminder to everyone that, you know, before we had beta-2 microglobulin as a test, we used to use the Dewey-Salmon staging system as was mentioned here, which was a very good staging system. The one we have now is probably a little bit more simplified, and all the things in the Dewey-Salmon, you know, are some of the things, if you really want to follow it strictly, might not be available everywhere either, but some of it you can use, and we used to use it even though we were not necessarily able to do certain things. Okay, that's good. So yeah, thank you for that. So one thing, maybe just for interest's sake, so what you've got there is your M protein going up by an absolute of 5, which is usually the minimum increase we want. We usually say it should increase by 5 plus 25, a 25% increase, but a minimum absolute of 5. So it looks like you've actually got that there. So I understand why you might have wanted to continue. But what is interesting, though, is that your albumin was actually still going up. So that makes one wonder about the accuracy of the 15. It's quite an interesting thing that one can have quite a bit of variability with your serum protein electrophoresis. So I think when in doubt, just as a practical point, it's sometimes worthwhile repeating it. I also think this shows something else that is quite interesting and sometimes useful, is that if you're resource constrained, and I think it's a topic we need to discuss at times, that you can start off a diagnosis doing your albumin, total protein, M component, like we've got here from May 2021, albumin 27, total protein 99, M protein 49. And then if you really, if cost is a big issue, you could initially monitor your patient by doing an albumin and total protein only. If your albumin is going up, your total protein is coming down nicely, then you know your patient is busy responding and you can see everything else is improving. And then maybe after every third cycle or so, do the whole thing to see where you are. I mean, if you really want to do it according to the book, when on treatment, you've got to do it monthly. But it's just a tip if you're resource constrained. It's one way of doing things a little bit more cheaply. But yeah, that would be my comment there. And then I wanted to ask about the zoledronic acid. So zoledronic acid is more affordable now. It used to be quite expensive, meaning that even in Cape Town, we're not able to use it according to the ASCO and other guidelines. So we use it less frequently. So it was quite interesting to see that you could use it every 6 weeks. Are you able to source it, I would imagine, at a reasonable cost? Because
for
that's
this patient,
yes,
we could use it every 6 weeks because his former employer was willing to pay for it.
Oh, that's impressive. That's great, because it's quite a nice modern treatment that you are giving the patient. So I understand where the balance comes from. Okay, great. Thank you. I don't know if there are any other
Thank you, Prof.
Other comments or thoughts from anyone? Okay, back to you, Moses.
There's one question in the chat box. Judy, would you want to answer that one?
Maybe just maybe just read out the question, and
yes.
I see that I lost that question when I was disconnected.
When you logged out, yes. So you said good clinical presentation. Was there a family history of a similar disease?
For this particular patient, there was no family history of this particular disease. He's actually the first one in his family to have such a disease. That is in his immediate family.
Thank you so much, Judy. Maybe I should just comment also on that, on what Prophet said about accuracy of the 15, and definitely it's a concern because unfortunately in our setting we don't have a public laboratory or a laboratory in the public hospital that is doing the SPEPs and the serum-free light chain. So these tests are sent to private laboratories, and unfortunately, some of the patients, they don't send to a single lab. They may send to one lab this month, and next month maybe the other lab is cheaper, and they send to that lab. Why we do them sometimes less frequently is mainly due to finances. Yes, and definitely I think I see Andrew commenting there about LDH, and we're actually looking through to see where the LDH is. We're just looking through the results to see where the LDH is, but we couldn't find it. So we are not sure whether it wasn't done or it was lost somewhere because our laboratory information management system is not so good.
Great. That was good. Thanks, Moses. Thanks, Andrew, for that comment. Moses, over to you.
Let me share my screen just now. Sorry. Right. Let me just start again. Don't know why I can't share it. Oh, there it is. All right, can you see my screen?
We can, thank you.
All right. Okay, so I'm going to just discuss the diagnosis and treatment of multiple myeloma in sub-Saharan Africa. So the outline, I'm going to talk about the epidemiology and then go on to diagnosis and then the treatment modalities available and some research activity in multiple myeloma. And then we discuss on the challenges and possible solutions to some of these challenges. Sub-Saharan Africa, as I said, it includes about 46 countries that only exclude 7 countries there, up there in the North Africa, including Egypt, Tunisia, Algeria. They are excluded, and I think some part of Sudan is also excluded. So the whole region down here is the Sub-Saharan Africa. And just general statistics about Sub-Saharan Africa, it has got about 46 countries, and it's divided into Western, Eastern, Central, and Southern Sub-Saharan Africa, with a total population of about 1.1 billion. And as I said, 46 countries, and the GDP per capita is about $1,500 US, and about 38%, almost 40% of the people actually classified as poor. And just an interesting figure there about net immigration. We are losing about 2 million people per year going somewhere to greener pastures in the developed countries. And before I start talking about the myeloma statistics in Sub-Saharan Africa, I just thought of highlighting a few from the SEER data from the United States of America. So they are saying the estimated new cases in 2022 is about 34,470 patients being diagnosed of multiple myeloma. And this is about 1.8% of new cancer cases. And about 12,640 are expected to die of this cancer, which is about 2% of all cancer deaths. So it's quite a significant population that we are talking about, 34,000 new cases diagnosed. And as of 2019, there were estimated almost 160,000 people living with multiple myeloma in the United States. And the 5-year relative survival is about 58% there in the US. And these graphs, they just show the changes with time of the overall survival and the death rate. And of the rate of new cases, right? So the average is around 1975, it was just below 5 per 100,000 persons. But it has been progressively increasing, such that now it is about actually above 7 per 100,000 persons. However, the good thing, the death rate, it seems to be almost stable. There was a bit of an increase around 1995, 2000. I'm not so sure why, but it is now back to 3 per 100,000 persons. And this is the graph. The graph below just shows the 5-year relative survival, which has been progressively increasing. And this data and good news to all the hematologists and patients as well, because this shows that whatever has been, all the developments, all the supportive measures, all the specific treatment modalities have been having an impact, such that now the 5-year relative survival is almost 60% from almost about 25% in 1975. Just a few more details. It's more prevalent, it's more common in males than in females, and it seems to be much higher in the Black population there. It's almost 2 times or even more in blacks than in whites. And the median age at diagnosis is about 69. Let's see, and also the median age of death is about 75 there. But also interestingly, the death rate in the Black Americans is actually more or less actually double that of the white Americans there. Now we are back to Sub-Saharan Africa. So we have got a lot of challenges, especially when it comes to data. When I was making this presentation, it was not an easy task because the data is quite disintegrated. We do not have integrated data sets or registries for cancer in Sub-Saharan Africa, and the data is usually obtained from individual national cancer registries and research studies from specific regions. So let's say in South Africa, maybe we have data for Johannesburg, but no data like reported in researches for Durban or for Cape Town. And the other thing is data completeness or accuracy for generalization is likely an issue due to variable diagnostic and therapeutic resources among and within countries in Sub-Saharan Africa. This was an epidemiological study published in Lancet Global Health. I just wanted to highlight that for myeloma, there has been an increase from 1990 to 2017. There's been a clear increase in the number of diagnosed patients. And this one, I got it from the Cancer in Sub-Saharan Africa, Volume 3, from the International Agency for Research Council, just showing some of the data that is available or that was available around 2010 to 2017. Yes, to 2017. And you can see the numbers are highly variable, especially looking at some of the populations. I can just show you, like for Mozambique here, which is, I think there were just 2 regions of Mozambique that reported, Beira and Maputo. And you can't believe that a whole country like Mozambique with such a large population can have only 8 patients with multiple myeloma being reported. And this is also true for other countries, quite populous countries like Nigeria. Here I've got in Abuja, one of the big cities, reporting about 3 male patients having multiple myeloma and also 3 female patients. So the data collection itself in Sub-Saharan Africa is quite questionable. It's quite, I may say it's quite poor because our numbers, I don't think they reflect what is on the ground. Then there were some studies that I managed to get in Sub-Saharan Africa. There is the first one that I'm going to discuss. It was a PhD study by Prof. Patel, which was multiple myeloma in southern. It was actually in Southern Africa, 1992 to 1997. However, most of these patients were coming from Johannesburg in Soweto. It was a prospective cohort, about 170 consecutive patients seen. The male to female ratio of 1.45 to 1, so more males diagnosed. And median or mean age was about 61.4. Not too different from the American data that we presented, but this is about about 5 years younger. and the peak frequency was in the 6th and 7th decades, which is similar to the data that we reviewed, of the American data that we reviewed. Let me try to remove this. Okay, so some other studies that I could manage to find that were done in sub-Saharan Africa, those are most of the studies that I could find. 1, 2, 3, 4, 5, 6, 7, 8, 9. So quite a few studies, and the one that that had the largest cohort, which was actually a retrospective study by Van der Waal. Actually, it was his MED study at Wits. It collected data from 1998 to 2010, a retrospective study of about 289 patients. With a mean age of about 58, which is much younger as well than what was reported in America. You can see the youngest patient even 26 years, but there was no difference in the in terms of who is more affected, males or females. If you look elsewhere in Africa, just small numbers. These were mostly case series, 30, 20 patients only reported. So what are some of the risk factors for multiple myeloma in sub-Saharan Africa? The general risk factors that we always talk about, the increasing age, male gender, genetics, they remain some of the important risk factors. But importantly, I should mention that the genetic studies is incomplete. There is no genetic studies that was done to actually prove that genetics is actually a risk factor in multiple myeloma in Africa. But we know from Black Americans that genetics plays a role. And risk in Black African population is higher than in other racial groups, as I mentioned. And other possible risk factors include viral infections. I think from the largest cohort that we have, no, actually for viral infections, it was mentioned in Prof. Patel's study, as well as the agricultural exposure, where where in that study, it was noticed that there was significantly higher number of patients coming from these, from farms, either working in farms or owning farms or spending a lot of time in the farms. But it was not, they couldn't find the real factor in the farms that was leading to increased risk factor. A study in Nigeria found an increased incidence in those patients in oil-producing areas. For the diagnosis of multiple myeloma, the clinical profile is generally similar to that described for multiple myeloma elsewhere in the world, with exceptions. And these include the majority of patients present with advanced stage disease. As Judy presented for our patient, presented in Judy's Salmon stage 3. And a lot, I'll show the data just now from the studies that are there, that quite the bulk of the patients, they present in advanced stage. Secondly, the symptoms and signs of presentations are quite overt and exaggerated when compared to those presenting in the Western world. And then the laboratory characteristics are also typical of that described in other regions of the world. This is just shows the clinical features of multiple myeloma in 3 of the studies that were done in sub-Saharan Africa. And as we can see, the bone pain is the is the most common presentation. Most patients present with bone pain. Over 90% from Prof. Patel's study, and anemia is also a major presentation. But interestingly, the patients presenting with pathological fracture, actually with vertebral compressions, as well as those presenting with paraparesis, they're quite actually a significant number. You can see in this study from Nigeria, over 25%, over a third of patients, they were presenting with paraparesis, which is quite not an interesting figure to see. Yeah. And then on the laboratory diagnostics, as I said, there is not much data. And this is from the study by Van der Waalt, whereby most of the cytogenetic studies, with the karyotyping actually failed in most patients. I think it out of the 280, almost 280 patients, only 17 had results. So that's quite a big challenge, because a lot of patients, in a lot of patients, the cytogenetics were either not done or were unsuccessful. And also the fish analysis, there was nothing really more common in our setting than elsewhere. And still under diagnostics, the imaging, the availability of imaging is another important issue. Most of the patients have got access to skeletal surveys, the x-rays, but we know the challenge now is the sensitivity of x-rays may be impaired, and there's a chance of missing those lytic lesions in about 30% of patients. And now it speaks now to the availability of other imaging studies like CT scan, low-dose CT scan, MRI scan, PET scan, and is shown in this study by this retrospective study by Van der Waalt. We can see that the availability of these more advanced imaging modalities is quite minimal. You can imagine for a population of 280 patients, only about 6 or 7 patients managed to get a CT scan in 2010 or something like that. So the access is quite a big challenge for these more advanced imaging modalities. Then I'm going to discuss about the treatment of multiple myeloma in sub-Saharan Africa. So as we know, the treatment focuses on supportive modalities as well as the specific modalities. And these supportive modalities that I've listed here, that's not an exhaustive list, but I just needed to discuss some of these, especially taking into consideration the presentation by Judith, as well as some of the challenges that we face in sub-Saharan Africa. So most of our patients, they present quite late. As Judith presented, our patient, I think he started having backache about a year prior to presenting to us. And during that time, a lot of these patients, they are given analgesia, and most of the time they are given these NSAIDs, and these contribute to the renal impairment that we see at presentation. And the second thing that I wanted to discuss, is blood product support. Quite a lot of these patients, they present with anemia, not just anemia, but a lot of them, they present with grade 4 symptomatic anemia, say that they may actually require transfusion. In most cases, the availability of other supportive measures like erythropoietin is not readily available. And of course, one of the important things that we should talk about while we're still talking about anemia there is always to make sure that the patients are screened for other reversible causes of anemia, such as iron deficiency and also in particular B12 deficiency, because these patients are they've got a higher risk of having B12 deficiency. But blood product support is very important in multiple myeloma during the initial management and also during the care of these patients. And the third thing, acute management in patients presenting with hyperviscosity. This is quite a challenge in quite a lot of sub-Saharan countries because of the limited availability of the machines to do the plasmapheresis. And in most cases, these patients are then either started on high-dose steroids that may also assist, as well as the chemotherapy. Management of infection, very important. Management of hypercalcemia, very important. I'm going to show you some data just showing that there's quite high early mortality that was shown in the study at Chris Hani Baragwanath. About 47.6% of those patients did not live after 3 months after diagnosis because of early deaths, and these early deaths they're contributed to a high number by the infections. Then radiotherapy, which is very important. You noticed how important it was in our patient, but many African countries they have no access. Ready access to radiotherapy machines, and that can be a challenge, especially in those patients who present with acute spinal cord compression. Another important treatment modality is dialysis. A lot of our patients present with renal impairment, and in a sub-Saharan African context, dialysis is a major challenge. I remember my days at Chris Hani Baragwanath, it was quite a nightmare to get dialysis for a patient with a malignancy. Same applies here in Zimbabwe. It's quite a nightmare getting dialysis. So that's another important factor that we should always think about when we talk about supportive modalities in sub-Saharan Africa. Then there is also limited access to the orthopedic and spinal surgeons, because just imagine if we've got a lack of hematologists in sub-Saharan Africa, there's also a lack of these orthopedic and spinal surgeons. Our patient was lucky because he had the medical aid, and he was, I think, the medical aid could also, I think it was the employer actually, could also manage to fund for some of these procedures, the CT guided biopsy to be done privately. It was actually done privately. I don't think it was done in government. And then lastly, under the supportive modalities that I want to discuss is the access to palliative care modalities. I think one of the important things that we should always think about is to make sure that our patients have got access to palliative care from the diagnosis, and we make sure that this is given throughout their treatment. Under specific modalities, the modalities, they include chemotherapy for induction, consolidation, as well as maintenance. Then autologous stem cell transplant. So transplantation, it depends on the transplant eligibility. But one of the most big challenges in the sub-Saharan Africa is the access to transplant services. And if I'm not mistaken, I hope I've got my Nigerian friends here and friends from other countries. If I'm not mistaken, transplant services may actually be only available in South Africa. So that's a big challenge for sub-Saharan Africa. And then maintenance chemotherapy. A lot of centers, they do what is called drug holiday, but of course, now with more data coming, I think more centers are giving maintenance either in the form of an immunomodulatory drug or a proteasome inhibitor such as bortezomib. And another big challenge is treatment of relapse or in the relapse or refractory setting. There is a very good article here in the South African Medical Journal by Dr. Fazel from Tygerberg on approach to the diagnosis and management of multiple myeloma. Of course, it's more of an approach, and it's not necessarily talking about what is happening in the sub-Saharan Africa, but it's a very good approach to diagnosis and management. And another important article that I could find, this was a multinational study in which I think I've highlighted Prof. Lo's name there, which was more of an observational trial, and unfortunately, this was mainly, I think maybe Prof is going to enlighten us, but I think it was mainly patients in Cape Town at UCT as well, at Groote Schuur Hospital as well, and another important one here from Nigeria. I think what I highlighted there is one of the important factors there to say the mean duration of survival of all patients was only 7 months, with only 13% of patients surviving at 2 years, which is quite typical of what is happening in the African countries. And most of the treatments that were used here, they were actually in the form of VAD, vincristine, adriamycin, and dexamethasone, and melphalan and prednisolone. All right. Another study that that is from Nigeria as well, published in 2017, and importantly, also showing that the mean duration from onset of symptoms to diagnosis was actually more than a year, just like what we saw in our in the patient that Judith presented, this patient from Harare. And importantly, over 60% of patients, they were coming in Jury Salmon stage 3. And as of the treatment, there are important things that I highlighted there. Only about 38% of patients received the bisphosphonates. And we all know that myeloma is mainly a bone disease. And you can imagine the limited availability of these bisphosphonates, which is typical of what we see in sub-Saharan Africa. And yeah, the access to there was actually no patient who was transplanted in this study, and only about 7% of myeloma patients survived up to 5 years post-diagnosis, while we're talking about almost 60% 5-year survival for patients in the United States of America. Okay, sorry. just some more data on first-line therapeutic modalities that have been noticed in some researches that have been published. From Van der Woud study at Chris Baragwanath, most of the patients, they were actually on melphalan and prednisolone, about 2/3 of the patients. And about 1/3 of the patients, they were actually on Saharan. That was between 1998 and 2010. But of course, I know that there have been some changes, but these have been the treatment modalities that have been there. And you can see the complete remission rate with melphalan and prednisolone was quite low, about 2%, about three patients got into complete remission, which is less than 5%. And a bit higher, about 12% of patients got into complete remission with severe type of chemotherapy. And during that period, only 9 patients managed to receive autologous stem cell transplant. Of course, the numbers have increased after 2010, but we don't have published data so far. And this is just trying to look into relapse disease, which is quite a big challenge in our sub-Saharan Africa. We always hear about the second generation proteasome inhibitors, the carfilzomibs, the ixazomibs, daratumumab, and for the anti-CD38, and the other generations of immunomodulatory drugs, which are largely not available in the especially in the public sector, from where most of our patients are seen. So in this study at Chris Baragwanath, most of those patients were still getting the same drugs that we're talking about, the melphalan, prednisolones, the Saharan, monotherapy with thalidomide, and also maybe delayed stem cell transplants. All right, so now I'm going to just focus on monitoring of response to treatment, what we do in most of our patients. So there is clinical monitoring. So like in the patient that Judith presented, you are looking at a patient who presented in ECOG stage 4, bedridden, and now some weeks later, 4 to 6 weeks later, the patient is coming walking on a Zima, with a Zima frame. Clinical monitoring, very important. And also for those patients who present with symptomatic anemia, how they improve, and the bone pain. The laboratory monitoring, most of the centers, I think we've got access to basic blood tests such as full blood count, U&E, calcium, magnesium, and phosphate, LDH, total protein, as Prof was talking about, and albumin. We've got access to those, and generally most of the patients are monitored as such. Access to more specialized tests such as serum protein electrophoresis and serum free light chains is a bit of a challenge because of costs, and so sometimes we may do these tests on a 3-monthly basis, or as much as the patient can afford. Repeat bone marrow to assess response is not usual, because we usually monitor these patients biochemically, but especially in a patient who has got non-secretory myeloma, we sometimes do that. And imaging studies, they may be repeated to assess for bone disease, the progression of bone disease, and especially extramedullary disease. However, the availability of most of these, except for general X-rays, is limited. So just from because I was in South Africa recently, I know what some of the things that are currently available for treatment of multiple myeloma there. Bortezomib is now available in many treatment centers, especially for transplant eligible patients. and autologous stem cell transplant seems to be more available. Of course, there was a big drop in the number of patients who were transplanted between 2019 and now because of the COVID-19. I'm not so sure about access to lenalidomide, especially for patients in the public sector, but thalidomide is more readily available. And the question is, does it have similar efficacy to lenalidomide? And access to other newer therapies is based mainly on compassionate basis. I remember Prof. Vernon Lowe posting some of these links on him SA WhatsApp group to say that you may apply for some of these newer therapies on compassionate basis. And in the private sector, there is actually wider access to these therapies, to the newer therapies that we hear about in many conferences. But the challenge, we don't have publications on current practice and on current therapies that are available in South Africa and efficacy of these newer modalities, especially in the South African setting, where we have got a population that may be that is actually different to most of these European and American centers. And in Zimbabwe, some of the challenges, we've got late presentation of patients, challenges with access to optimal supportive care, especially in public sector, with the resultant high early mortality, out-of-pocket payment of services and medications for the majority of patients, such that if you cannot afford some of the treatment modalities, there will be quite big challenges. And the regimens that are commonly used, they include melphalan, prednisolone, then bortezomib. We're getting quite a lot of this, the cheaper version of the bortezomib. So in most cases, we usually include bortezomib in our treatment plans. So we may combine it with cyclophosphamide, dexamethasone, or with thalidomide and dexamethasone, or in some, especially private patients, lenalidomide is also available. Transplant services are not available, and especially patients with the relapse are quite a big challenge because we don't have access to most of the newer therapies. So I'm just going to, in the next few minutes, I'm going to share just the prognostic data in multiple myeloma from the researches that have been done. I think I'm just going to mention that actually most of the patients, in Prof. Patel's study in the 90s, most of the patients were presenting in stage 3, over 75%, almost 75% of patients, which still remained the same even between 2000 and 2010 in Van der Waalt's study at Chris Hani Baragwanath, where most of the patients were still presenting at higher stages. You can see stage 3A and stage 3B combined is about 76% of patients presenting in as advanced disease. Of course, these patients could be staged with the international staging system, and about almost 60% of patients were presenting in stage 3. As I said earlier, 47%, almost 47.3% of the patients, they died within 3 months of diagnosis, which is quite a worrying figure. And it speaks mainly to the availability of supportive care measures. However, as I say, this is not peculiar to Chris Hani Baragwanath. This is a paper from Nigeria whereby only as I think I've shown this data, only 7% of the patients survived up to 5 years post-diagnosis. So we can see that we've got a big challenge. We've got a lot of challenges in this sub-Saharan Africa, from diagnosis to treatment. And I think this slide just shows some of the prognostic factors that were noticed in the multiple myeloma patients, and we can see that a higher serum total protein, a higher serum paraprotein above 10 grams per liter, and stage 3 disease, high urea and high total protein, as well as a low white cell count, had a bad prognostic value. And before I finish, I will just talk about HIV and multiple myeloma in sub-Saharan Africa, because we know that HIV is a big problem in sub-Saharan Africa. So there's no convincing data of association. However, those patients who are HIV infected and diagnosed of multiple myeloma tend to be younger, and they've got a higher frequency of plasmacytomas and a lower incidence of immunoparesis. And there's no difference in incidence of infections at presentations to those who are HIV negative. And there's less chance of receiving autologous stem cell transplant in these patients. I don't know whether this is a subjective or objective assessment, but there's generally less chance of them getting transplanted. And overall survival may be lower due to what has been reported as more aggressive disease and less chance of being transplanted. However, it's a controversial one, because some studies, they haven't found a difference in the overall survival. Maybe I should just also mention about research activities. There is, I think we're going to discuss it, but there is a research that is at the moment ongoing, whereby the Bristol Myers Squibb Foundation has jumped on the ship to actually assist with funding for multiple myeloma research in sub-Saharan Africa, so that we up the game and make sure that multiple myeloma is well diagnosed, is known by the people, and is well treated. I think that's my presentation. We've discussed about the challenges, and maybe we are going to talk about the solutions during the presentation. Thank you so much.
Moses, thank you very much for a very, very interesting presentation. Before I open for questions, can I just double check with you? Did you say in the beginning that Judith had another case that she was going to present? Moses, you're muted.
I think because of time, we may skip that one.
Okay.
But
right.
it was yeah.
That's fine. That gives us a bit of time for some discussion. So
Yes.
a couple of things while people are putting some comments in the chat box. First, I want to say thank you very much. I think this is a really interesting overview of what is going on in a region larger than what we usually think of. And I think it was very, very interesting for me. I think it also emphasizes the need for good data and the need for hematologists. I think the low numbers are definitely, like you said, an underestimation. We need to have better data to understand what is happening and you know, what the real numbers are in our setting. I just wanted to comment, you asked me about the EMOS trial that we were involved with. That was from during my time in Bloemfontein. So just to acknowledge the University of the Free State. And it was a study looking at how myeloma is treated around the world. And they were interested in real world data. The other thing I might just point out, and let me just quickly share my screen, is perhaps this study that we did also during my time in Bloemfontein. We had a wonderful student, Jeroen de Groot from Holland, from Amsterdam, that spent a year with us. And we did this study to look at concomitant HIV in newly diagnosed myeloma patients. And I really think this is a study worth repeating and to look at as maybe as a multi-center initiative. And in this particular study, we just looked at our own data in Bloemfontein, 16 HIV positive, 73 HIV negative patients. But what was fascinating, the HIV patients presented at a significantly younger age, but had less osteolytic lesions. Maybe their bones were still stronger, more resilient, but they also had less renal impairment, and their neutrophil counts were lower, which could have been the HIV itself. But all the rest was pretty much the same. Their CD4 counts were relatively high. Few of them had abnormal free light kappa lambda ratios. But now this, I think, well, I at least thought this was quite interesting. And I want to take you to a table. Yeah. If you look at the type of paraproteins we found, all the HIV patients had IgG paraproteins, either kappa or lambda, where you saw the normal distribution in the HIV negative patients. I then went at the time to look at the literature. At that time, there were in total, I think, 30-something patients with HIV ever described with myeloma. I think except for one, all the patients had an IgG paraprotein. So I thought that's really unusual and fascinating, and I would really be interested, now that you've mentioned that the Van der Walt study, which I think is unpublished, to see what they found, how many of these others they found, IgAs and so forth, light chain disease. And that would be fascinating to note. The other thing, just maybe for comparison's sake, I think our data on the presenting features were quite similar to the ones you've mentioned. If you just look here, and the myelomas, of course, the HIV positives. So yeah, and then the other study I'd like to just acknowledge is that of Justin de Tooy, where he looked at the predictors for stem cell mobilization in autologous transplant, which included a large number of myeloma patients. So it's been published very, very recently. So I think that is useful to look at. Okay, while people are thinking of questions, I want to quickly throw up a poll, and I'd like everyone to quickly look at the above, and let's give it 15 seconds or 20 seconds to answer. Which of the following are known associations with multiple myeloma? You can only choose one option. So let's hear what you think. Okay. I'll give it 5 more seconds. Okay, here we go. Right, so just to show you quickly for interest's sake. So look, I carefully crafted the question to say known associations, not known causes. So the correct answer is all of the above. The known risk factors for myeloma is Agent Orange, which, as far as I know, was never used in Africa, but it was used in very many parts of the world as a herbicide. Initially, I'm not sure if it was initially, but importantly in the Vietnam War. High body mass index is also a known risk factor. Family history, also a known risk factor. Vitamin D deficiency is a very strong association. I personally believe there might be something there. It would explain a lot of things. It would explain why patients who are have darker skin are at higher risk. It would also explain why patients with higher body mass index have higher risk, because That's also associated with low vitamin D, and vitamin D, as many know, is associated with a range of cancers. And the Mayo Clinic has done some interesting work on vitamin D deficiency, which is very highly prevalent in multiple myeloma, but a clear cause has not been established. So that's just for interest sake. Let's see what's in the chat box. See, Rita's got some interesting ideas. If we could set up hematology sans frontières. Yeah, Rita, I agree with you. That's definitely what we're working towards. Moses, you mentioned that there were more patients diagnosed with myeloma in oil-producing regions. And the question for me was just, do you think there's a link, or do you think it's because the oil-producing regions are economically better off, so has better healthcare and maybe better access to diagnostics and doctors and specialists? I think that was in Nigeria or Niger or somewhere. What do you think?
Yeah, that's what I thought as well. Is it a real factor there to say these patients are mainly in that region? Because as one of the things that we see here in Zimbabwe is most of the patients are diagnosed in Harare, because that's the capital city. That's where most facilities are. So I think that's the same thing in the oil-rich areas. That's where maybe most of the facilities for diagnosis and treatment are, and then it seems like most of the patients are coming from there.
Thank you. Yes, and then I see someone asked in the chat box, Carissa Manaru, good to know the experiences of our neighbors. Thank you, Moses and Judith. How can these challenges be addressed? Moses, any ideas? I commend you for returning home to practice. The brain drains are driven by political and systemic issues that appear beyond repair and out of our hands. Moses, any words, any ideas on the first question, and any words of encouragement on the second?
Thank you, Carissa. She was my consultant at VETS when I was, I think, a first year, second year registrar there. So definitely there are challenges, but I think we should start doing something rather than just saying the politics and the economy is like that. And I'm quite happy that Rita has posted something on that Hematology Sans Frontières, and also the collaborations that are starting to happen thanks to the BMSF Foundation funding as well. So there is a lot of work that is happening inside that. There's collaboration between countries in sub-Saharan Africa to make sure that we improve the care. And also, as you know, something that has been going on and something that I've benefited from, the education, whereby there's I'm trained in South Africa and go back to Zimbabwe. So I think there's more room for training, for collaborations across Africa as the economics and politics are being fixed.
Yeah, I agree with you. And I must say, it's quite exciting for me to see that there is growth in access in our neighboring countries as well as in South Africa. Dr. Elizabeth Botsile, who I see in the room, hi Liz, graduated from University of the Free State. She's gone back to Botswana, doing some great work there. Dr. Simba Kudakwashe, originally from Zimbabwe. He has literally just sent me a WhatsApp an hour ago to say they've arrived safely in Namibia, where he'll be starting as the first clinical hematologist in Namibia. And I think all of us need to work very hard at advocating on every level, government, wherever we can, to get support, to get people trained. We really believe that if we can train another 100 for the SADC, 100 clinical hematologists for the SADC region in the next 10 years or so, we're going to make a massive impact, and perhaps another 200 for Africa, it will be absolutely brilliant. And you'll see, as we've got more people that can make the diagnoses and treat these patients, that a lot of lives will be saved. So well done on the good work you are doing, and Elson and Barry as well out in Zimbabwe. I think that's really wonderful and commendable, and under challenging circumstances. Right, I want to just remind everyone that the link for the CPD points is in the chat box. You can just scroll up to 1700 hours. You'll see Prof. Estelle Verberg, who organizes and coordinates this meeting. Thank you very much, Estelle. Has pasted the link there. You can just add that meeting code to the link when you open the link. And also a big thank you to Elzaan van Rensburg, who works as part of our team to organize these meetings. Melanie Davids, who does part of the admin, and we're actually busy setting up, hopefully soon, an automated system and a proper website where all of these things will be hosted. At the moment, these are hosted still at UCT. And if you need to watch the video or the recording afterwards, you can just email Melanie. Then I'd like to just tell everyone of a great initiative, which Moses already alluded to, which is the Blood SA Foundation initiative to provide support to all participating centers interested in working on multiple myeloma with the support and help of the BMS Foundation. This is a project that in our center, Prof. Estelle Verberg and myself are leading. Moses is leading it in Zimbabwe, and there's people leading it from every other faculty in the country with hematologists. So there's some exciting things coming. Multi-center study on myeloma specifically is going to be happening in the next year. With that, a big thank you again, Moses and Judith, for great presentations, wonderful work. And we look forward to seeing everybody again next week for a session on a topic that is super important, not always discussed: autoimmune hemolytic anemia, with all its fascinating and interesting diagnostics and therapeutic issues. And the team from SMU will be presenting. We look forward to seeing all of you there. And with that, I wish you all a wonderful evening and a good afternoon. Bye-bye.